Finals SAQ 96 Chronic Pain. A. How should you manage the perioperative opioid requirements of a patient who is having elective surgery and who takes regular opioids for non-malignant pain? Preoperative. Ensure the patient's preoperative pain is fully managed. Delay non-urgent surgery if not yet fully optimized. Involve chronic pain team. May include use of non-opioids. Establish the reason for the patient's opioid analgesia use. This may have implications for the perioperative period, such as positioning limitations. Establish drug dose, duration of use, and route of administration. Formulate plan for post-operative pain relief, depending on the nature of surgery. Consideration for degree of pain likely to be involved. Whether the patient will be able to take medications via oral route. And make calculations of equivalence if the patient's condition will dictate conversion of intraoperative analgesia post-operatively. Need to ensure usual 24-hour dose, plus extra to manage pain from surgery. Normal doses of oral slow release and immediate release of opioids to be taken on the day of surgery. Intraoperative. The decision as to whether to continue opioid patches depends on the nature of surgery. For example, it may be appropriate to continue patch with non-opioid analgesics and immediate release oral morphine for breakthrough pain if day case surgery with low predicted pain, whereas if the patient is to have major surgery and need for intravenous opioid is predicted, it would be more appropriate to calculate the equivalent dose of IV morphine and include this in the overall predicted 24-hour morphine dose. Furthermore, transdermal absorption perioperatively may not be reliable and is certainly not titratable. If the patch is warm, for example, under forced air warmer, then absorption will be increased. If the skin is cold, then it will decrease. Buprenorphine is a partial antagonist, so may complicate top-up dosing with morphine. All staff should be made aware of the physical location of the patch if it is left on, so that it may be removed in cases of opioid narcosis. Other intraoperative considerations: awareness that larger doses of morphine intraoperatively will be required to achieve the same effect compared to opioid-naive patients. Use of multimodal analgesia, such as paracetamol, NSAIDs, ketamine, neuraxial and regional techniques, to reduce the overall opioid requirements. Immediately post-operatively, in view of the risk of either overdosing or withdrawal, it may be appropriate to manage the patient in a high dependency setting than would normally be dictated by the nature of the surgery, or extended recovery may be required. Be aware of signs of opioid withdrawal, such as adrenergic hyperactivity, tachycardia, palpitations, sweating, hypertension, hypothermia, pillow erection and sweating, generalized malaise, flu-like symptoms and myalgia, abdominal cramps, diarrhea, nausea and vomiting, lacrimation and rhinorrhea and yawning. Be aware of signs of opioid overdosing, such as sedation, reduced conscious level and coma, reduced respiratory rate, reduced tidal volume, respiratory depression, cyanosis and respi arrest, and pinpoint pupils. Ensure regular input from inpatient acute pain team. Higher bolus doses of morphine in PCA will need to be kept under review regularly, as equivalence calculations are approximate. The patient is therefore at risk of both unrelieved pain and narcosis. Use of pain score to assess unrelieved pain. Use of opioid-sparing analgesia, such as paracetamol, NSAIDs unless contraindicated. Regional analgesia, single shot or catheter technique. Use of neuraxial analgesia, ketamine infusion, gabapentinoids, lidocaine or magnesium infusion as appropriate. If IV morphine is used, convert back to oral dosing as soon as feasible. Consider any change in renal function post-operatively, as this impacts opioid clearance. Make a plan for de-escalation of opioids post-operatively and include this in discharge paperwork. B. Give the conversion factors for oral tramadol, codeine and oxycodone to the equianalgesic oral morphine dose. Equivalent doses to 10 mg oral morphine equals tramadol 100 mg, codeine 100 mg, and oxycodone 6.6 mg. C. What are the perioperative implications of an existing spinal cord stimulator? Spinal cord stimulators are used for neuropathic pain, CRPS, and ischemic pain due to angina or peripheral vascular disease. They achieve their effect through the gate control theory and modulation of release of other neurotransmitters. Leads are surgically placed in the dorsal epidural space, which usually requires laminotomy or percutaneously via Tohi needle. The leads are commonly placed at T8 or T9 level. The pulse generator can be left externally to the body initially to check efficacy and then placed in a subcutaneous pocket, such as the upper back, abdomen, or gluteal region, and the leads tunneled to it subcutaneously. Seek advice from the team that manages the patient's spinal cord stimulator. Check battery life and any other issues. The stimulator should be turned off during surgery to avoid accidental reprogramming or activation by electromagnetic interference. Care with positioning. Device may have pressure area implications. Avoid excessive flexion, extension or rotational movements of the spine, which increases the risk of lead migration, especially in the early weeks after insertion. Avoid neuraxial techniques due to the risk of damage to leads or infection. Thoracic epidurals are absolutely contraindicated. If neuraxial technique is essential, it should be undertaken under specialist supervision with strict asepsis, under fluoroscopic guidance, and bearing in mind that epidural spread may be impeded by fibrosis in association with the leads. Bipolar diatemy should be used wherever possible. If unipolar diatemy is absolutely necessary, position the return plate to avoid electrical passage through the SCS. D. What additional perioperative precautions should be taken if the patient has an intrathecal drug delivery system? These systems deliver drug into the CSF, thus directly to the dorsal horn, meaning much smaller doses are required. Drugs used includes opioids, local anesthetics, clonidine or ziconotide for refractory pain, and baclofen for spasticity. The pump may be external or fully implanted, with reservoir filling performed percutaneously. It may have a fixed rate or be programmable. It may be sited anywhere from the thoracic level to the second sacral segment. Risk includes dural granuloma, leg edema, infection, CSF leak, drug errors, complications and issues associated with the pump or catheter, and human factor errors relating to lack of familiarity with intrathecal drug delivery systems. These should only be accessed, used or filled by clinicians experienced in their use. Significant risk of infection, so spinal anesthesia only if benefits considered to outweigh the risk. Consider location of the ITDD system, as this must be avoided. Intrathecal bolus may be given via the device if it is at a suitable level. However, the system will be primed with the usual drug it delivers, so beware of delivering a large bolus along with the intended bolus. Meticulous aseptic technique when utilizing the ITDD system to avoid infection. Epidural catheter insertion is feasible above or below the ITDD system, site but only if benefits outweigh the risk. Opioid dosing as for opioid-naive patient, unless the patient is also taking oral opioids. No diatemy within 30 cm of the pump or catheter. These are my references. Thank you.